Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on retrosternal goiter and Thymic Carcinoid, a rare coexistence. You can watch this lecture and other lectures by visiting my YouTube channel using the URL at the bottom of the slide. Thyroid and thymus are two glands located on both sides of the thoracic outlet. This is the thyroid gland in the anterior region of the neck, and this is the thymus gland in the anterior mediastinum. They have a similarity in their shape. Each one consists of two lobes, and there are other similarities as well. Retrosternal goiter. The thyroid gland is located in the neck. However, an enlarged thyroid gland goiter may extend into the thorax, specifically into the anterior mediastinum. When more than half the gland is located below the thoracic inlet, the condition is named retrosternal goiter. Retrosternal goiter is not uncommon and has been identified since 1749. So in this CT scan image, the retrosternal goiter is evident as a big part of the enlarged thyroid gland is located in the anterior mediastinum below the level of the thoracic inlet. The thymus gland. The term thymus is probably derived from the Greek word thymus, meaning spirit, or from the Latin word thyme, referring to a herb of a similar shape. The thymus is derived from the third pharyngeal pouch, located initially in the neck, but during the 8th week of gestation, it descends into its final destination in the anterior mediastinum. The thymus is especially well developed and big size in the newborn and the growing child, but after puberty, it undergoes a process of gradual involution and is replaced by fatty tissue. Histologically, the thymus consists of lymphocytes, thymocytes, and epithelial stroma, beside argentaffinoma cells. The Greek physician Rufus from Ephesus was the first to mention the thymus as a gland in the 1st century AD. However, people required centuries to discover its true function. Initially, the thymus was considered the emotional center of the body. Later on, the thymus was accepted to have no specific function. In the 16th century, Ambroise Paré, 1510 to 1590, a French surgeon, described it as an excrescence. An excrescence means a growth, whereas others thought of it as a cushion to prevent damage to the heart or overexpansion of the lungs in the newborn. It wasn't until 1970s when subsets of T cells were precisely identified in the thymus, the role of the thymus as a lymphoid organ became clear. Argentaffinoma, or the Golgi-Tisky cells, argentaffin or the Golgi disc cells are present in all structures derived from the primitive endoderm, including derivatives of the pharyngeal arches, the tracheobronchial tree, the gastrointestinal canal, the pancreatic, and the bile ducts. However, the chief locations of these cells are the tracheobronchial tree and the gastrointestinal tracts. Regardless their location, the tumor produced by these cells is called carcinoid tumor. Thymic carcinoid tumor. The term carcinoid tumor or argentaffinoma was introduced by Oberndorfer 1907 to designate a tumor which histologically resembled an undifferentiated carcinoma, but behaved in a benign fashion. About 85% of the carcinoid tumors are located in the intestine and 10% in the lung. Rosai and Higa identified thymic carcinoid as a separate entity from thymoma in 1972. Although thymic carcinoid has a similar ultrastructure to carcinoid tumors of other organs, this very rare tumor has a poor prognosis due to its tendency to local and distant spread. In this lecture, although both retrosternal goiter and thymic carcinoid tumor develop in the anterior mediastinum, literature search revealed no patient having both lesions at the same time. Presented herein is a 55-year-old Iraqi man with a retrosternal multinodular goiter and a localized solitary primary thymic carcinoid. Thymic tumor was simultaneously removed along right thyroid lobectomy via a median sternotomy extended to the neck with a good early outcome. The case: a man of 55 admitted to Suleymaniya Teaching Hospital, Suleymaniya, Iraq, on the 9th of October 2006 with an anterior neck mass of 30 years duration associated with effort dyspnea and chest pain in the preceding few months, but no sweating, flushing, or diarrhea. Sweating, flushing, and diarrhea are features of the carcinoid syndrome. Physical examination revealed a visible thyroid enlargement, mainly of the right lobe, with increasing dyspnea on arm elevation. So that was the patient, and his plain chest radiograph preoperatively showed left-sided tracheal deviation with a rounded left hilar mass. The diagnostic workup included, beside the plain chest X-ray, electrocardiography, echocardiography, fiber optic bronchoscopy, and thyroid function tests, which were all normal. Fine needle aspiration and cytology revealed benign follicular epithelial thyroid cells, so there was no evidence of thyroid malignancy. That was the chest CT scan showing a large, well-defined, solid anterior mediastinal mass. And that was the neck CT scan revealing a large complex thyroid mass with calcification, displacing the trachea to the left side. The patient underwent one-session surgery. Endotracheal intubation wasn't difficult. Once the sternum was divided via median sternotomy, the mediastinal mass was found loosely adherent to the great vessels, and it was easily resected. So that was the anterior mediastinal mass. Median sternotomy incision was then extended into the neck. Thyroid enlargement was huge, extending down into the mediastinum. Right thyroid lobectomy was performed. After securing hemostasis and placement of drains, the wound was closed in layers. So that was the right thyroid lobectomy specimen. And that was the post-operative photograph of the patient showing the median sternotomy incision with a cervical extension. Post-operatively, the trachea regained its central position as shown by this plain chest radiograph. The histopathological examination revealed a colloid goiter and a thymic carcinoid tumor. This slide and the subsequent slides show the microscopic appearance of the thymic carcinoid. The microscopic appearance of thymic carcinoid tumor was in the form of nests of uniform small round cells with small rounded nuclei and pink cytoplasm with no pleomorphism and no necrosis, with rosette-like formation, a characteristic appearance shown by this slide as well as the subsequent slides. Small, rounded, uniform cells arranged in rosettes with rounded nuclei and pink cytoplasm with no pleomorphism and no necrosis. Discussion. In this report and in this presentation, a man of 55 with thymic carcinoid tumor and retrosternal goiter is described. Preoperative workup failed to arrive at definitive tissue diagnosis. Although most retrosternal goiters can be removed via a cervical incision, median sternotomy was chosen due to coexistence of the anterior mediastinal mass with the retrosternal goiter in this patient. Worthy to note, both thymus and thyroid glands normally contain argentaffin cells. These cells are named C cells in the thyroid gland and can give rise to thyroid medullary carcinoma. However, the chief locations of argentaffin cells are the gastrointestinal and respiratory tracts. In this case, neither thyroid medullary carcinoma nor gastrointestinal or bronchial carcinoid tumors were present. Hence, the tumor was solitary and primary. Moreover, The tumor did not invade the nearby structures or metastasize distantly. The carcinoid syndrome that usually results from serotonin secretion was absent. Retrosternal goiter is said to exist in up to 1/5 of patients undergoing thyroidectomy, 90% of which are located in the anterior mediastinum. Diagnosis of retrosternal goiter is most frequently made in the 5th or 6th decades with symptoms related to tracheal or esophageal compression by the slow-growing thyroid gland. Similarly, this 55-year-old patient had a long-standing goiter associated with shortness of breath. Primary thymic carcinoid tumor is very rare. Just 100 cases have been reported worldwide by the year 1994. From 1995 to 2010, Ahen et al. From South Korea found only 18 cases. Most of them were males with a male to female ratio of 15:6. The patients with thymic carcinoid may be asymptomatic or have compression symptoms such as chest pain, dyspnea, cough, and superior vena cava obstruction. Cushing's syndrome may be seen in half the patients. Large carcinoid tumor may cause flushing, cyanosis, and hypertension, the so-called carcinoid syndrome, due to the secretion of serotonin. Many thymic carcinoids are small, less than 2 centimeters in size, and composed of epithelial cells with small uniform nuclei and acidophilic or vacuolated cytoplasm. They grow slowly and frequently invade the lung and pericardium. Fine needle aspiration and cytology may be diagnostic. However, these tumors are usually diagnosed by surgical exploration or mediastinoscopy. Complete resection of the tumor remains the most important prognostic factor. Despite extensive resection, recurrence may occur years later. Thyroid medullary carcinoma has morphological and behavioral characteristics similar to carcinoid tumor. Clegg et al. Had reported the case of a 21-year-old man in whom multifocal bronchial carcinoid was diagnosed initially, but at necropsy, metastatic thyroid medullary carcinoma was found. Ectopic thyroid tissue may be found in the thymus. Cassisi et al. Described a 3 by 4 centimeter ectopic thyroid tissue in the thymus gland in a 49-year-old lady after total thyroidectomy. Noteworthy, the presented patient has neither thyroid medullary carcinoma nor ectopic thyroid. Well, the closing remarks, thyroid and thymus. Thyroid and thymus share many common features: proximity to thoracic outlet, the presence of argentaffin cells, occurrence of tumors sharing similar morphological and behavioral characteristics, namely thyroid medullary carcinoma and thymic carcinoid, involvement by autoimmune diseases such as Hashimoto's disease and Graves' disease of the thyroid, and myasthenia gravis of the thymus, and a similar surgical approach are just few to mention. While a lot is known about thyroid, still we know little about its neighbor gland, the thymus. As the Greek philosopher Socrates said, "What I know is that I know nothing." This saying seems to fit the thymus gland, as the more you deal with it, the more you believe you know very little about it. And the take-home message of this lecture: surgery is the treatment of choice for retrosternal goiter due to possible existence of thyroid malignancy in retrosternal goiter and the potential for airway compromise. Coexistence of retrosternal goiter and the rare Thymic Carcinoid tumor is very rare. Surgery is thought to be curative in the present case, as no invasion of nearby structures and no distant metastases were reported. Well, this presentation is based on two of my previous publications. I have published a case report named Retrosternal Goiter and Thymic Carcinoid, a rare coexistence, in the year 2017 in the Journal of Egyptian Society of Cardiothoracic Surgery, and have published an editorial named Thyroid and Thymus, refreshing some facts, in the Journal of Soleimani Medical College. And this is the list of references for our presentation of today. And with this picture of Wisdom House, Dar al-Hikmah in Baghdad, I conclude my lecture. Thank you for watching the lecture. This is Professor Abdussalam Yassin Taha signing off from the College of Medicine, University of Soleimani.